Join us today. Welcome to the webinar 2024 Mid-Year Advocacy Update. My name is Angie Fiedler-Sutton, and I use the pronouns she, her. I'm with the National Behavioral Health Association Providers. The National Behavioral Health Association Providers, otherwise known as NBHAP, is a national trade membership association that provides education and advocacy for behavioral health care providers and related entities. We are the leading and unifying voice of addiction-focused treatment programs. We provide membership benefits such as networking and access to compliance information, educational opportunities such as this webinar and our Certificate in Addiction Treatment Marketing, the CATM, and advocacy efforts to keep those in the industry aware of new laws and regulations that may be coming that will affect them. Working in the behavioral health industry or managing an organization in the industry can be incredibly complex and filled with ever changing information. NBHAP gives you the resources to stay on top of the rules and regulations for your organization to stay compliant. For more information about NBHAP, you can visit our website at www.nbhap.org. And now, it's my pleasure to introduce our presenter today. Andrew Kessler, JD, is founder and principal of Slingshot Solutions, LLC, a consultation firm that specializes in behavioral health policy. His clients, past and present, include the International Certification and Reciprocity Consortium, ICNRC, the California Consortium of Addiction Programs and Professionals, CCAP, and BHAP. With 20 years of policy experience and over a decade in behavioral health, Kessler is a fixture in circles that advocate for substance abuse treatment, prevention, and research. He collaborates frequently with congressional offices, the White House Office of National Drug Control Policy, the National Institute on Drug Abuse, NIDA, the Substance Abuse and Mental Health Services Administration, SAMHSA, and other federal actors. Kessler has written legislation and report language adopted by both the House and Senate Appropriations Committees and has presented orally before such bodies as the Scientific Management Review Board, the National Conference on Addictive Disorders, and the College on Problems of Drug Dependence. Andrew, thank you for taking the time to present today. With that, I will hand the webinar over to you.
Thank you, Angie, and welcome to all of you attending today. First point of order, you may have seen me glancing over there. It's because I'm looking out my window at some very large thunder clouds that are approaching my location in Fairfax, Virginia. So if you hear any noises from my end that sound like large rumbles of thunder, that's exactly what they are. So just giving you a warning and hoping that the power doesn't go out. Thank you, thanks to all of you for joining today. I see some of you in the chat, your locations. We have a great geographic distribution. We have the East Coast, the West Coast, the Midwest, different settings, treatment, recovery, corrections. I'm glad that we have the corrections community here today. We're going to have some of our talk is going to focus on corrections policies, so you're in the right place. And as Angie said, Andrew Kessler of Slingshot Solutions, welcome to my home office. As I said, in Fairfax, Virginia. I don't blur my background because I like everyone to see what makes me me. I'm not all about policy 24/7. I'm a huge fan of English soccer. I'm a huge fan of horses. And I'm a huge fan of the artwork of my daughter, which is up there. So in any event, that's who I am. Those are my interests. But during the day from sun up to sundown, I work on SUD policy for NBHAP, and here to give you a little update on the progress we've made in the last 6 months and maybe some of the progress that we haven't made. So we can dispense with introductions. Rosemary, I see you're a fan of Irish soccer. There's only one team I follow in Ireland, and that's in Ireland. That's Bray, the Bray Wanderers. They're right outside Dublin, a little south, and they're a team I went to see when I was in Ireland on my honeymoon. So I only follow Irish soccer a little bit. Sorry, Rosemary. There is, of course, a lot going on, as per usual, with SUD policy, but that doesn't mean that there's a lot going on with legislation. There's lots of different ways to impact policy in Washington, and one way is through legislation, but there are other ways to do it as well. Most of our policy work this year has actually revolved around rulemaking. Federal agencies don't need Congress to act on their behalf if they want to make a change. they can change rules within certain parameters as they see fit once a certain procedure has been followed, which almost always includes comments from the public, review after review, and so on and so forth. Now, there is still some legislative work going on, but just not just not as much as we'd like to see. In fact, those of you who may pay attention to Washington and politics and policy may have heard that last year, 2023, at the end of the year, when all is said and done, it was one of the least productive Congresses ever, with the fewest amount of legislation passed in well over 150 years. Very unproductive. Could have something to do with 30 different votes on electing 2 different speakers, other factors, but there was a lot of time spent on working on things not related to legislation. So as a result, we had a pretty slow year when it came to Congress. Don, just to answer your question, if I will touch on the FY25 approach process, yes, I will be touching on that in pretty good detail. That's kind of the middle chunk of my presentation. So sit tight. We're going to get to it. So before we talk about 25, we got to talk about 24, because you don't know where you are until you know where you've been. You have to see what kind of progress you're making, what kind of progress you're not making, on and on and on. So as we deal with that, let's take a look at FY24 first. Technically, the FY process is supposed to be done September 30th. That's according to the letter of the law. If everything operated in a vacuum and we operated, without human error, that's when it's supposed to take place. Congress has been ignoring this deadline with more and more brazen indifference each year for the past almost several decades. We see a CR every year this year. A CR, for those of you not familiar, is a continuing resolution to avoid the government from shutting down. That simply means that all government entities continue functioning at current levels until Congress passes full appropriations. So sometimes there's a 30-day CR. Sometimes it goes into December. More recently, it's gone into January. A few years ago, it dipped into February. This time around, it went all the way into late March, which is not good. Because even though the funding gets there eventually, it leaves the agencies that fund the states and the communities and the grants that many of you rely on, whether they be block grants, state opioid response grants, grants from DOJ like Burn Jag, any number of grants, it gives agencies a lot of uncertainty as to how much they're going to have to distribute, when they're going to be able to distribute it. It creates a very, very nervous environment, and it's just not good for business. To sum it up as succinctly as I can. So we were well into March, which is almost half the fiscal year. So looking at 24, every HHS agency suffered cuts, with the amounts varying. Many of us on this call are obviously concerned with SAMHSA. That's who funds the block grants. That's who funds a lot of the other programs that we're interested in. By percentage, if you were to take all the HHS agencies and look at all their cuts, SAMHSA suffered the smallest cut, which is in a way a victory. It's a little hollow, it's a little Pyrrhic, but still a win. I want to use NIH as a barometer. For those of you who don't know, NIH is the National Institutes of Health. This is an institute that funds the National Heart, Lung, and Blood Institute, the National Cancer Institute, the National Institute of Digestive Disease and Kidney Disorders, the National Institute of Neurological Disease, the National Institute of Child Health, anything you could imagine. Billions and billions of dollars of research, including the National Institute on Drug Abuse and the National Institute on Alcohol Abuse. NIH is a darling of Congress and most White Houses. NIH funding is as close to a sacred cow as you can get on Capitol Hill. Even the lawmakers who oppose big increases across the board for government programs tend to like NIH. Why? You can probably find a grant from NIH, several grants from NIH in just about every congressional district in the country. So especially districts with large universities. If you're in a large metropolitan area, odds are good you have a university that has millions of dollars coming in from NIH. So Congress tends to like NIH. NIH, for the first time, I think, in over 27, possibly 30 years, at least 25 years, possibly 30 years, suffered a cut. That shows you how incredibly harsh the funding environment is. Yes, we care about SUD and mental health and behavioral health on this webinar, but you cannot take away the surrounding environment. Call it what you want. All boats rise with the tide. What's good for the goose is good for the gander. If funding overall is bad, odds are good funding for your pet projects are going to be bad. Unless, as we've been told by people on Capitol Hill, if you have strong bipartisan support, you may squeak by without getting too hurt. And that's pretty much exactly what happened. So even though SAMHSA got hit with a tiny little cut, it was really nothing compared to what NIH, CDC, and HRSA had to go through, which was much larger cuts in terms of percentage of their budget. The SAPT block grant, which goes to the states based on population, went unchanged. No cuts at all. State opioid response grants, unchanged. No cuts at all. CDC's overdose data to action, which is funded over $500 million, unchanged. This kind of shows you that we kind of did okay with our advocacy. Everything is relative. Would I have liked increases? Of course. Did we advocate for increases? Of course. As the Rolling Stones said, you can't always get what you want. It's one of the creeds I live by, not only because it's the Rolling Stones and a great song, it happens to be true. So we're kind of holding our own, if nothing else, because of the bipartisan support we have for this issue. Now, this is comparing, before we get to 25, this is comparing 23 to 24. And you can see that most of it's pretty flat. There were a couple of small increases in technical assistance, as you can see. The first column is FY23. The second column is FY24. And the question came up, doesn't unchanged really mean a loss with inflation? Yes, it does. Healthcare inflation as well, because a lot of us deal in healthcare. Healthcare inflation tends to outpace regular inflation. So yes, but again, all things being relative, no one, with the exception of defense, really got any increases. So flat is kind of like, flat is the new increase, I guess you could say. I'll get to that in a little bit when we talk about 25. The one significant increase that we saw was 988. Right now, suicide prevention is a very hot topic in behavioral health. Congress seems to have a lot of bipartisan support for 988. The White House has a lot of support for 988. I'm going to get to that more in a little bit when I talk about White House initiatives. So 988 got a slight increase. And here are some other programs. Again, first column 23, second column 24, all flat. So this kind of sets up what we're looking at for 25. Why? Because it's the same Congress, same White House. You really don't see big changes in odd fiscal years because a Congress lasts for 2 years. So it's all the same people. No new elections have been held. Same president, same White House, same Congress. And there's a presidential election coming up, very tense House and Senate races coming up. No one is going out on a limb with spending because you're always going to make someone happy and you're always going to make someone mad. So we are expecting some CRs to carry us through the end of the new year. And then the new Congress has its work cut out for it when they come to town, especially if there's a change in the White House. No one knows how that's going to go, least of all me. So as we get to 25 and we look at our advocacy for 2025, the motto has become fight for flat. And this is not accepting defeat. This is not us saying, well, last year was bad, so this year is going to be bad. This is based on intelligence we have gathered on Capitol Hill. I can't say who. Let's just say both Democrats and Republicans in the House and Senate all seem to agree that if you have pet projects that you need to get funded, flat is probably going to be a good outcome. We have been told if you want to succeed, fight for flat. Now, does that mean we ask for flat? No, you ask for more. So you get flat. Really basic negotiating. It's going to be a very, very difficult year for appropriations. One, because of the dichotomy between the House and Senate. Two, between the dichotomy between the House and the White House. Three, because of the unpredictable nature of the election. So remains to be seen procedurally how this all comes about. Flat, Rosemary, what is flat? Flat means the same funding as last year. Flat funding. What you got in 24, you'll get in 25. No increase, no decrease, which turns out, as pointed out before, to be a small decrease due to the cost of inflation. So let's talk about the specific programs that we advocate for, just so you have an idea of what our priorities are when it comes to NBHAP. SOR, these are the state opioid response grants. These came into existence about a little less than 10 years ago and have evolved and grown both in terms of their budget and in terms of what can be done with them. It is similar to the block grant, the SAPT block grant, in the sense that it is administered by SAMHSA, is administered by the same state offices that administer the block grant, your single state agencies. And it's based on a formula with one caveat. While the block grant is a formula based solely on population, California gets the most, Wyoming gets the least, everything else in between. The SOR grant has a booster if you're a state that has one of the 10 worst overdose rates. So if you're a small state like West Virginia or New Hampshire, but you have a high overdose rate, you get a little more. Not a significant amount, but a little more. You know, call it a cherry on top. So that's the SOR grant. I know for a fact that the SOR grant is used for a variety of different things: treatment, recovery, workforce. I know that in West Virginia, Oregon, Alabama, we've seen SOR grants go to workforce to pay for like training costs for new peers or new counselors or test costs. I've seen it go to recovery support services, a variety of different issues that the block grant doesn't always go to. So because the block grant in its statute is much more limited in what it can pay for. So we obviously advocate for the SOR grant. According to the CDC, and I didn't know where to put the slide, so I kind of just slipped it into the middle of the presentation. I was thinking I could put it at the beginning as a narrative. I could put it as the end as a wrap up. I could put it right in the middle because everything you say at the beginning is forgotten by the end, so on. But for the first time in over a decade, for the first time, I believe in 11 years, maybe even 12, overdose rates have dropped in 3% in a 12-month period. Okay. Every month, the CDC publishes numbers on overdose rates, which we admit are not as accurate as they need to be because the data is hard to gather, which we admit are difficult to see as complete because of the population we're dealing with and the difficulty in contacting them. However, based on the data we have and the collection methods we have seen overdose rates drop 3% in a 12-month period for the first time, right? This is why we advocate. If you have ever sat around and said, why do we do this? We now have your reason. It is starting to work. Greater invest 3%, not a lot. We're not where we need to be. I want you to imagine you say to yourself, I'm setting a goal to run the marathon next year, and I'm going to do it. And you've never run a marathon before. You've never even run a 5-miler before. And you train and you train. And the next day you go out and you run the marathon and the firing gun starts and you've run the first mile and you're feeling good. That's where we're at. Hey, I am on the way. That's how I feel with this 3% number. We got a drop. I remember when numbers stayed a few years ago, I think it was about 7 years ago, numbers didn't increase. And we were like, okay, maybe we're getting somewhere. Turns out we weren't just yet, but change takes time. Advocacy takes time, and it takes time for advocacy. Because if I were to advocate for appropriations, as we were just talking about, in this cycle, which is FY25, I wouldn't know if we got that money until next January. And that money wouldn't go out to the states until next March at the earliest. So it's like a year delayed. Your advocacy, before you start to see results, just in terms of the money going out the door, is at best operating at maximum efficiency about a year delayed. Then the states have to decide what to do with the money. Then the money has to be put into programs, and the programs have to get up and running. And then we have to find the populations that we serve. It is not an easy task. It is slow. Change is slow. Change in Washington is incredibly slow. But seeing this drop, I thought, was a significant victory. Something is starting to work. Something. And you can't tell me that the money we've invested in these programs isn't part of the reason. So I see your question there, Don, about fatal overdoses or total overdoses. I believe it was fatal. It was fatal overdoses. I don't have the exact answer, but I believe it was fatal. And if during this presentation I can pull it up, I will put the study in. I'll drop it in the chat and we can all see. So another program, Star Loan Repayment. One of the major problems we have in behavioral health is workforce. Our workforce is spread thin. We have not nearly enough workforce to meet demand. And whether you're looking at the statistics from HRSA at HHS, whether you're looking at the statistics from the Bureau of Labor Statistics, whatever that may be, the numbers show supply is not meeting demand, especially for SUD counselors and psychiatrists. When it comes to other professions, the numbers say maybe we've got enough to squeak by, maybe we don't. But when it comes to SUD and psychiatry, the workforce numbers fall short in the tens of thousands. So we need to advocate for workforce programs. And one of those programs is Star Loan Repayment. Now, it continues to be funded at $40 million. That may sound like a lot, but if each applicant for a Star Loan Repayment program, which is a loan repayment program for anyone working in the SUD space up to $250,000 in exchange for up to 6 years of service in an underserved behavioral health area. Even if every recipient only gets $100,000, that's only 400 people we can service. And that is if every dollar goes to loan repayment, which it doesn't because it administrative costs, so on and so on. That's not a lot. Last year, only 60 new SUD counselors were funded. Now, other professionals were funded, addiction medicine, psychology, social work, all important, all have their roles to play, and we support every one of them. But where the shortage is in SED counselors, and we funded 60 new ones. So when I say 40 million, it sounds like a lot. In reality, it's not nearly enough. Let's try adding a zero there. Workforce is a critical issue that is not being addressed. And when I say it's not being addressed, I mean it in two areas. One, just the sheer dollar amounts invested. There are plenty of loan repayment programs out there. There's the STAR, there's the National Health Service Corps. There's plenty. Our problem is in retention. And there are no government programs to fight for funding for retention of behavioral health professionals. And we need to work on that. And we will, but that takes a lot more because we need to create a new program from scratch. So we fight for this because it's better than nothing, but it's still not nearly enough. I do want to talk about some legislation. I know I said that legislation is slow and it's not passing all that much. And it's not. Every bill I'm about to talk to you about, there's a couple of bills I want to talk to you about that we support, has not passed. It is these pieces of legislation have been introduced, but they're important because they represent very big changes in the system of care. It's important to have a beacon, a pie in the sky that you're shooting for. That's what these bills are. I would be shocked, and I can almost guarantee none of these bills will pass in their current form. But you start with your ideal and you negotiate from there. So I want to talk to you about a few pieces of legislation. Right now, if you were to talk to anyone on Capitol Hill about workforce, mental health, or SUD, the first question you would get from a representative, from staff is, tell me about peers. That's all they want to talk about. Now, me personally, I have several clients that deal in workforce for the whole spectrum, all of SUD, all of mental health. I represent them all. But the buzzword on Capitol Hill right now is peers. So one of the pieces of legislation we see is the Peers in Medicare Act. This was introduced by Judy Chu of California. From those of you from California, I believe she's in the Pasadena area. Not 100% sure. She's somewhere just outside Los Angeles. And this would provide Medicare coverage of peer support services when delivered by federally qualified health centers, or FQHCs, or CCBHCs, Certified Community Behavioral Health Clinics. You have to understand the federal government is very limited in what they can dictate in terms of insurance coverage for SUD. Because the only thing they can control outright is two things: Medicare, Medicaid, and veterans benefits. And that's it. And to a degree, DOD, but that's through TRICARE. So that's a whole other story. So that's where you start. But it's important, and it can't be overlooked, because Medicare and Medicaid will eventually seep into the private system takes their cues from Medicare and Medicaid. This is a time tested. So changes to Medicare and Medicaid, always what you want to do first. This is a long shot for a few different reasons. The first is we just accomplished getting Medicare coverage for mental health, social work, and SUD counselors just last year. And they are counselors who in many cases are licensed and credentialed by the state and so on and so forth. We're not there yet with peers. Many peers do go through a credentialing process, but the landscape is very much in flux. Peer standards vary greatly state to state, and I mean greatly. Yes, SAMHSA has their model standards, which are a good starting point. Certain certification boards may have standards, good starting point. But for social workers, for mental health counselors, standards for licensing and credentialing are uniform. With SUD, we're getting there. With peers, we're nowhere close. So very, very difficult to say that Medicare should cover these services until you can prove to lawmakers that there is a standard being met by these professionals. So this one's going to need some time. It's bold, it's necessary, it's going to need some time. The next piece of legislation we're working on concerning peers is the bipartisan Providing Empathetic and Effective Recovery Support Act. This is sponsored bipartisan. You can see from people across the country, coast to coast, Oregon, California, Kansas, Virginia, Indiana, whole countries represented, Democrats, Republican. Very, very strong support for this bill. And this bill is about recovery. Now, I know some of you work in treatment, some of you work in correction, some of you work in prevention, some of you work in recovery. Recovery is just starting to make inroads into policy. For many years, the policy only reflected treatment protocols. That's because most lawmakers and staff don't know the difference. We have to go to the Hill and educate them. This is what treatment is. This is what recovery is. There's a difference. Different services, different professionals, different settings. So the fact that recovery is finally getting recognition is a good sign. This bill would direct the Office of Management and Budget to revise the standard occupational classification system to create a distinct classification for peer support specialists. Almost every occupation that is recognized in the United States is part of the standard occupational classification. Doctor, nurse, psychologist, get out of healthcare, engineer, lawyer, truck driver, pilot. These are professions that are recognized by the standard occupational classification of the Department of Labor. Until peers are recognized as a distinct profession, policy that dictates how they can be used is a fight, like the last piece of legislation I mentioned. That's why this legislation, I wouldn't say is a higher priority, but passing this first would make other legislation much simpler when it comes to peers. It would also codify the Office of Recovery in the Substance Abuse Mental Health Services Administration. I'm not going to read this to you because I hate it when I'm on a webinar and there's a slide with lots of words and people just read them. You all can read. If you want to read this, go ahead. I'll just summarize it. 3 years ago, SAMHSA established an Office of Recovery within the Office of the Director. This was at the behest and the pleasure of the director of SAMHSA, Dr. Miriam Delphin-Rittman. It only exists within the Office of the Director because she wants it to, meaning the next director, Democrat or Republican, can shut it down. This legislation, if passed, would establish by statute the Office of Recovery. The main goal of the Office of Recovery is to expand the peer workforce and expand recovery support services across the United States. That's it. Pretty noble goal, if you ask me. So pretty important that Congress pass legislation that says this office is now a part of SAMHSA. So it can have its own budget, have its own committed staff, so on and so forth. Because right now, it only exists because SAMHSA wants it to exist. That can change with the next director, regardless of political party. The bill would also instruct the Department of Health and Human Services, in partnership with Justice, to research states' criminal background screening process. What does this mean? Right now, many people who want to be peers can't be because they want to work in settings that require a criminal background check. And unfortunately, many people who want to become peers have had run-ins with the criminal justice system and have a conviction. And in many settings they should work in, they cannot because the criminal conviction bars them from working in that setting. We want this reevaluated. This would not put an end to that practice, but would call for reexamining that. Is it necessary to have such laws in place that someone with one felony conviction for possession can't work in a certain setting? I think you see where I'm going with this. It would lift the stigma and it would take a large number of people who want to work as peers and allow them to work in settings they are currently barred from. That's it. And states will still be able to make those determinations. If you feel that certain convictions are beyond the pale, and I'm just pulling this off the top of my head, this is not in the legislation, sexual assault, first-degree battery, okay. But we're talking about crimes like possession of marijuana or possession of methamphetamine, 10, 15 years ago. Let's reevaluate. Let's see how we can do. Let's get the workforce slots filled. And finally, I want to talk about the Second Chance Act. For those of you in criminal justice, this is the classic example of how we in mental health and substance use disorder have a burden that no other public health area has. No other public health advocacy setting has to worry about the impact of the criminal justice system on the well-being of their consumers. None. So the Second Chance Act was passed in 2008, but Congress has a rule called reauthorization. Usually, when a program is created, it's given a shelf life, 5 years, 10 years. When that shelf life expires, the program needs to be what we call reauthorized. It is not mandatory to be reauthorized to continue to get funding, but it's a good idea because a lot of lawmakers on Capitol Hill, if they don't want to fund something, their convenient go-to excuse is, well, it wasn't reauthorized. It is also an opportunity to reevaluate the law and say, what has changed? How can this program improve? What has changed between 2008 and 2024 with our knowledge, with our advances that should be part of this in order to make it as efficient as possible? So this act has been reauthorized. It was passed under a Republican, reauthorized under Democrats, reauthorized under another Republican. Now, 5 years after the last reauth, we're up for reauthorization again. Bipartisan support, to be sure. But there are two major changes that Congress is looking to make that would really revolutionize the Second Chance Act. The proposed reauthorization would put in place stronger reentry services and supports for people released in prison and jails. And this would come in the form of casework, specifically casework with peers. It would expand the funding available for casework. It would expand the number of professionals available for casework, on and on and on. Okay. And perhaps the most important, it would strengthen provisions around transitional housing services. Studies show that one of the leading causes of recidivism post-release from incarceration is the lack of stable housing. Probably not coincidentally, studies show that one of the leading causes of people not being able to maintain wellness once recovering from substance use disorders or mental health disorders is the lack of stable housing. This is a win-win for the criminal justice system and for the SUD and mental health system. Stable housing plays a role that statistics show is far and away one of the top reasons people are able to get their lives back together. Because if you have to worry about where you're sleeping at night, how are you going to keep your mind on maintaining your health? It's a difficult thing to do. So we are putting a lot of effort into the Second Chance Act reauthorization. I want to wrap up in the next 5 to 7 minutes in case we have time for questions. So I only have a few more slides. I want to talk about just a few other subjects that we have our eye on. It's a broad subject, SUD and mental health, but there's been some movement. I talked about 988. I talked about workforce. Now I want to talk about very briefly about methadone. There have been changes to methadone policy. This started during the pandemic. People were being told not to be in crowded places, not to leave their homes if necessary. And those patients on methadone said, well, how's that going to work for me? So allowances were made for take-home doses and for mobile methadone clinics to go into neighborhoods where it would be easier for people to access their dosage. This proved to be tremendously successful. Diversion rates were infinitesimal, less than 2%. And it turned out to be one of the few, I hate to say it, bright spots of the pandemic. What HHS has chosen to do is make these changes permanent. So the allowances under the COVID emergency have been made permanent, and it allows for far, far easier access to take-home doses of methadone. Each OTP will work with their patients on how many days, 1 week, 2 weeks, I don't know. It's going to be up to the OTPs, or whether they want to do it at all, but it is now allowable. I can't say it's mandatory. If you say, give me a take-home dose, I can't say your OTP must comply, but it is allowable. Big change, and we hope that brings a lot of advances. There's also legislation being considered called MOTA, M-O-T-A-A, the Modernizing Opioid Treatment Access Act. And this is a much bigger step than the modification to the rules. Much, much bigger step. This would end the 50-year monopoly of OTPs. How you feel about that is up to you. I am telling you what the legislation would call for. This would allow board-certified addiction doctors and addiction psychiatrists to prescribe methadone to patients, basically like any other prescription, for distribution at pharmacies. Simple as that. The legislation is supported by the American Society of Addiction Medicine. It's supported by Faces and Voices of Recovery. It is also opposed by ATOD and by the National Association of Behavioral Health Providers, which are both OTP, have members, OTP trade associations that have OTPs as members. This, I don't want to take too long on because I could do a 1-hour webinar on this legislation. Very, very complex issue. I want you to know it's out there, it's being considered, and I'm going to keep you notified. I do these webinars twice a year. Next one will probably be post-election, and as I talk about what we're looking at for 2025, this could be part of it. I don't see much movement on it this year because even though there's been good support in the Senate, support by the House majority has been poor, so I don't see it moving. But this, if it were to pass, would be a seismic shift in drug policy. And it would change 50 years of policy that many think probably shouldn't have existed in the first place, but for the short-sightedness of the DEA. So full disclosure, clients that I represent have expressed their preference for this legislation to pass. So that's the position I have taken. NBHAP has not, I don't know if they've officially declared a position, but I've spoken with leadership and we're currently having very lengthy discussions on this legislation. As I mentioned earlier on, there's not a lot going on in Congress, so the White House kind of sees being left to them to pick up some slack. There's been a White House overdose initiative launched, which focuses on Narcan or naloxone. And it's been a nationwide call to action to save lives by increasing training and access. You know, they're asking businesses, they're asking entities, community organizations to train your employees on how and when to use opioid overdose reversal medication, ensure that kits are available, and to purchase and distribute opioid overdose reversal medication. So this is something the White House can do on their own. It's just they're just asking people to be involved. It didn't require an act of Congress. Like, for example, United Airlines pledged to be a part of it, and they said they would train all of their flight attendants and crew on how to use naloxone, keep it stocked on their flights. Certain restaurant chains said they would always have it on hand, train their employees. They're asking for entities to take part in this. Another White House initiative is the White House Suicide Initiative. I didn't get, I mentioned 988 earlier, and I mentioned how important that is in terms of policy and ramping up the funding, which seems to be on a decent track, all things considered, getting small increases in a time where increases are not necessarily abundant. So the White House created its inaugural federal action plan to put a national strategy into action. It identifies over 200 ways to address the growing mental health and suicidality crisis among Americans at all levels. One of the biggest problems we have with 988, the people to staff it, and the poor pay. If I told you you can earn an hourly wage answering 988, and then Chick-fil-A across the street says you can earn the same wage here, I'm going to go out on a limb and say most people would pick Chick-fil-A because you probably sleep better at night, not having to listen to the calls that are coming in. So it takes a very special breed of person to be on the other end of that phone. And we believe that they should be paid, like the job is moderately important, which it is, but pay is very poor. And we're having trouble filling those slots for 988 operators in the States. You can see here what the tenets of the plan are. The goals to increase support for the suicide prevention initiative. Last thing I'm going to mention is cannabis. Just last month, there was issued by the White House, I wouldn't say in cooperation, but DEA will obviously have to weigh in with DEA on moving cannabis from Schedule 1 to Schedule 3. Schedule 3, for those of you who aren't familiar with the DEA schedule, is other narcotics in that class include Tylenol with codeine, for example, is a Schedule 3 narcotic. Painkillers with a touch of narcotic, whether that be codeine or other more powerful drugs. So the reasoning being the criminal justice aspect, obviously. People being arrested for possession of marijuana, which is a Schedule 1 drug, obviously needs to change. However, there are obviously great concerns in the treatment and recovery community about the impact that easier access to cannabis could have, especially on youth. I am a person who has studied this subject profusely, and I will be one of the first to say that if you are a fully grown adult who every once in a while wants to enjoy a cannabis product, I really don't see the harm. My concern, and the concern of those I represent, is the impact of cannabis and THC on the developing brain, those under 25 who engage in use. So by making it more available, even though there will still be restrictions in place, we really are facing a potential public health challenge that we are ill-equipped to handle. So this one's really, really tricky. There you go. I've left enough time for Q&A if we have any. I see one in the chat that I'll get to in just a second. But there you have my information and my work with BHAP. And Angie, before you jump on, let me just see what this first question is. Would you think this shift to private providers being able to prescribe methadone most likely create a need for more pharmacy techs and fewer addiction counselors? I work in methadone. It's tough to say. The first way to answer that is it's tough to say how the pharmacies would react. Let's keep in mind that it's not as if you fire a starting gun and tomorrow, let's say this bill passes today, which they can't because they're not in session. Let's say they come back next week and say, oh, that MOTA Act, great, passed, signed. Do you think Tuesday morning pharmacies across the country are going to start stocking up on methadone? I can tell you the answer is no. I saw when naloxone became available over the counter how tough it was to get at some pharmacies and how slow they were to get it out. And, it's like, it's not a given that every pharmacy would automatically start doing this. What I do see it as, and if you were to ask me my ideal, what would this look like? Those of you familiar with CVS, they have something called the Minute Clinic. Walmart probably has it too. Walgreens probably has it too. Maybe Walmart. And what it is, it's a little cubicle with a door, and you can schedule an appointment, and you go into the door, and you can get a variety of health services. You may be in there getting a flu shot, a COVID shot, an STD check, an eye exam, an ear exam, a breathing test for asthma. You could be getting any number of these services that could be provided by a pharmacy tech. I just see adding getting your methadone dose there to those list of services. That's it. That's really all it is. So it would take, now keep in mind also, once a law passes, that's not all she wrote. There is, as I said, a rulemaking process. And who would be able to distribute it? How would it be distributed? Would it still have to be daily? Can you distribute take-home doses? All that would have to be worked out. So there would definitely be a need for more education of pharmacy techs. I know that many OTPs are thinking this could put them out of work. What I say to that is 80% of the counties in the United States don't have an OTP. So let's work on getting them the services they need first, and then let's worry about how it would impact OTP. I know for a fact some people like going to the OTP every day. It gives them a sense of community, gives them a sense of I don't want to say purpose, but I have talked to people on both sides of this issue, from people who are saying, I hate going there every day. I would rather just do anything else on the planet but do that, to people who say, I don't mind it. I do it on my way to work. I get my methadone dose and it's just part of my daily routine and I don't mind it at all. I have talked to OTP owners who are dead set against this. I have talked to OTP owners who are lobbying for this. So there's a lot to be worked out. I can't answer the question on logistics, but what I can tell you is how it would impact the workforce is more in the bottom half of my concerns than the top half.
Any other questions? While we're waiting, I have put in the chat, Andrew was a guest on our podcast, Destination Change, a few months ago. I put in the link in the chat, and it will also be on the page for that. So if you want to learn more about what it's like to be an advocate. Okay, I want to thank Andrew Kessler for presenting today. Thanks as well for you for participating. We hope you join us for future MBHAP webinars. You can sign up for our various newsletters, which include emails specific to upcoming events, at our website, www.nbhap.org. With that, this concludes today's webinar. Thanks again.